Good morning, everybody. It's great to see everyone this morning, hopefully with your coffee mug. You may notice something a little different. I'm not in my usual kitchen. I'm actually in a ballroom. We just had the California chapter meeting yesterday. And there's a chapter meeting today that I'm attending. So I'm in the ballroom where we're going to be having the meeting. But really, it's great to see everybody. Hopefully you have your coffee mugs and we come together each month to talk about great ideas, innovation, hot topics, and more with fascinating guests in the world of cardiology, medicine, healthcare, and beyond. I'm Dipti Itchhaporia, president of the American College of Cardiology, and I'm thrilled to welcome you all to our virtual coffee table. So we look forward to an interactive session today and have allotted the last half of the discussion for an open Q&A from all of the attendees. So I really also want to make sure that you put a chat question, but also be prepared when I call on you to be able to come on camera and ask your question. We also invite you to follow along on Twitter using the hashtag ACC Coffee Table. And really a reminder for virtual engagement, please remain muted when you're not speaking. We encourage the use of WebEx chat feature. At the end, we hope that you'll join us for the questions. If you're viewing this today on the WebEx application, I want you to click the layout button in the upper right corner, and under stage view, select stack for optimal experience. But without any further ado, I want to go ahead and introduce our two speakers. We're joined by Dr. Michelle Albert. She is the Walter A. Haas Lucy Stern Endowed Chair in Cardiology and Professor of Medicine at the University of California, San Francisco. Dr. Albert is the admissions dean for the UCSF Medical School and director of the Center for the Study of Adversity and Cardiovascular Disease, the Nurture Center. She's also president of the Association of Black Cardiologists and the 60th president of the Association of University Cardiologists. And she is the president-elect for the American Heart Association. Welcome, Dr. Albert. I also want to introduce Dr. Ed Childs, who's the chair of surgery and professor for trauma and critical care at the Morehouse School of Medicine. He is he's also co-edited Stigma and Prejudice with Rana Parekh, our chief diversity officer at the college, and co-authored the Massachusetts General Hospital textbook on diversity and cultural sensitivity in mental health. And he is an incoming Board of Trustees member for the American College of Cardiology. Welcome, Dr. Childs. So I think that first of all, welcome to both of you. You know, this has been quite, we were talking about this, reflecting at this meeting. Wow, what the last almost 2 years has been, right? Come March, it's going to be 2 years of the pandemic. And I will say that the pandemic has, for me, brought a few things in light, and I've written about this in my leadership page. One is health really matters, right? I think if we didn't believe that, we really have appreciated over the last 2 years how much health matters. I think that for the first time, we're starting to really, really talk about the fact that health and the economy are linked. And then interestingly, as we have seen the pandemic unfold and seen that, you know, the mortality for African Americans is almost twice what it has been for white Americans, the issue of health equity has really come into the focus, right? It's brought light to significant health inequities that have existed in our society really for decades. And so there has been this imperative for health equity. And we recognize that the imperative is there because if we really want good health for everybody, we really have to tackle this behemoth of health inequity. So I'm going to start with both of you to just, you know, comment on sort of your thoughts about where we are in this with the state of health inequities. You know, what do you think are some of the consequential disparities that we're dealing with now? Michelle, we'll start with you and then Ed.
Sure. So thank you, Dr. Itchhaporia, for having me on the program today. I'm really excited to look forward to our discussion. So when I think about the framework of health equity and where the disparities are, I think of about a couple of things. The first is I worry about our life expectancy statistics. You've already hinted to the fact that, you know, African Americans in particular have the lowest life expectancy in the country at 75 years. And although there's been improvements in in mortality and morbidity from cardiovascular disease over the last several decades, African Americans still have the highest mortality and morbidity. And that life expectancy statistic is tied to cardiovascular disease outcomes. And so it's really important, I think, like at a state level and a federal level, where funding for chronic diseases remain flat over time, although expenditures have gone up, that there's got to be some, focus on life expectancy itself, which is folded into health. I get it, but that's sort of a big issue. I also think that maternal health is another issue. Black maternal health and the maternal health of Alaskan Native persons in Alaska, in Alaskan individuals, where their mortality statistics are 2 to 4 fold higher than whites and Asians. The other thing is, as you hinted to as well, is the economic part of this. Economics is the underbelly of health disparities. About 24% of Blacks and Native persons, for example, live in poverty, and 60 million children live in poverty in this country, which is 1 in every 6 children. And then two other issues I'd like to bring up is, one is the fact that sort of there's a lot of housing discrimination that's been going on for 400 years, from the birth from slavery, and so health inequities have been present for at least 400 years. And quality neighborhood investments, neighborhood opportunities at the neighborhood level are tied to economics, and as such, really also drive the disparities. And I think at a federal and state level, this issue about chronic disease funding is something that is going to need to be paid attention to. And then lastly, I think diversity of the healthcare workforce is an important contributor to disparities, with no real moving of the needle for underrepresented persons in medicine over the last 3 decades, really, in their proportionality in medical school, which is what drives ultimately getting into leadership careers in medicine. And of course, all that starts in childhood in terms of opportunities.
And you know what? Just Michelle, your answer has brought so many questions to my mind, but I really want Ed for you to comment before we launch right into it.
First of all, thank you so much, Dr. Chapori, for having me today. And I'm honored to be here with Dr. Albert. So thank you so much. I think when we talk about healthcare disparities and we talk about what has happened over the last few years, it's very important that we look at the disease process in a holistic way. There was a term that was coined in the 90s talking about syndemic, and that is looking at the socioeconomic construct associated with diseases. And I think that's so important, and that highlights exactly what we're talking about. The healthcare disparities issues have come to the forefront because of the pandemic and seeing the great gaps that we see. First of all, how we access the healthcare system, and also some of the mortality and morbidity and mortality data associated with the patients in the system over the last few years. So I think we need to take a holistic view, and I am so happy we're having this conversation about healthcare disparities today.
So, Michelle, you brought up some good points. Ed, I agree with your thinking about the construct, but why should everybody care? Why should the cardiologist listening care? Why is this an important issue? I mean, we talked about that. There's an economic picture to be made. I mean, the Institute of Healthcare Improvements said that health inequities cost the United States $83 billion, and they estimate it's going to go up to $300 billion in 2050. Okay, I think people can wrap their head around, wow, maybe there's an opportunity here for us to cut costs that way. But really, why should they care? What makes them get up every day and think about this issue and want to do something about it?
I would say that, I would say three things, and they just go back to us as human beings. First, it is all about, what our values are. we getting to the point where we recognize that we have shared values. We are in the same ecosystem. We have the same fate. Okay, so if healthcare costs are the $300 billion mark that you gave, Dipti, is related to, actually a lot of it is related to premature death of Black persons in this country. And if it's related to premature death, then the problem there is then it hits all of the pockets of everybody, right? It also decreases the workforce, the eligible workforce, to be able to do innovations, for this country and for the world globally. So we should really care because of our shared fate, collective opportunities, and shared values fundamentally. And then all of that is tied into economics.
Ed, what do you think?
I agree 100%. You can't look at the economics of this crisis and not look at the social injustice. So people have a lot of compassion around both, actually, for different reasons at different times. But looking at the disease process and what it has done to the economy in the US and around the world is significant. We see it daily. And in addition, looking at the social injustice that we see associated with morbidity and patients not having access to care is also very heartbreaking. And to not have passion and compassion for both issues, I think we're missing out in the conversation.
Okay, so let's say they care, but say a cardiologist listening is saying, what can I do? I mean, wow, this is a huge problem. What can I do? Like, I'm just one person. I can barely make it through my day. I get up, I go early to see all these patients. I think I'm doing a good job, so I think it becomes almost overwhelming. So tell me about some of the thoughts that you both have. And I think you alluded to that. I think the workforce issue, and I will tell you that the college, for example, undertook a diversity and inclusion, perspective starting 2017, had a task force, and we're working on pipeline issues. Kim Williams was at this meeting and mentioned yesterday about the fact that he's much more likely to influence an African-American patient being an African-American physician. And that sometimes having people of similar color or race or whatever will make a difference in terms of the outcomes. So maybe comment about some of the solutions that you say, and what can this individual do? And then we can talk about collectively what we can do institutionally in other ways.
Right. So, I think a lot of things, so as Dipti, I had the opportunity to deliver a lecture for the American College of Cardiology on defining priorities related to health equity for cardiovascular care. And, in that presentation, I, outlined, I believe it was 7 priorities. And I think within all of those priorities, there are things that cardiologists can do. So one priority that I had outlined related to reforming cardiovascular teams, for example, from an interdisciplinary to an interdisciplinary model. So if you're part of a division of cardiology, one of the things you can do if you're the leader of the division or the chair of medicine is actually really enfold primary care physicians into the care that cardiologists and cardiac surgeons provide in order to have that seamless communication with patients, like let's say, for example, around blood pressure control, which is a big issue. That's just a little thing like on the clinical side, structurally advocating for the redesign of how our teams work. That's just a one really simple thing. I think also, at the cardiovascular division level, we can set up equity councils where the equity council is looking at several things, looking at the disparities within and around us in our divisions or cardiology, cardiac surgery, etc. And then beginning to identify, what are the things that the division can do, its doctors can do to help address the observed disparities. And that may mean working with peers as well. It may also mean, and then you got to set metrics to achieve your goals. So those are some examples. There's a ton of different things you can do, and then I think also on the educational side, and I'll stop. That in infusing in your rounds, teaching about healthcare disparities, and recognizing, and when you do that, I do that all the time when I'm on clinical service. I always look for an opportunity to introduce health equity into my discussions about heart failure or ICDs or the latest SGLT2 inhibitor. I think we have to make it part of our culture of discussion.
Ed, what are your thoughts?
I agree, and I think if you look at it on an individual basis, just as a physician, what can I do today? What can I do tomorrow? One of the things that I think is very important is to be in communication with your patient. It's amazing what happens if you call your patients the next day and to simple questions like, "Did you get your medication? Are you able to follow the instruction? Can I help you with anything that you don't understand?" These are some of the things that we can do as a physician to help each patient. Having this conversation, understanding the cultural differences in patients and how they may feel about the healthcare system, establishing trust with the patient so that they know that you're the individual that they can call at any time and get advice and information about whatever the disease process is. So these are some of the things that you can do as an individual physician each day to make a significant difference. Highlight some of the disparities on rounds when you're teaching the medical students and the residents and the fellows. So these are some things that you can really shed light, and it makes a significant difference. Providing respect to the entire team and to every patient are some of the things that are so important to develop trust and communication with your patient.
Yeah, I think those are really great points. But an individual physician may feel like, wow, if a patient can't afford to get their medications or something, what can I do? So talk about other solutions with institutions, payers, advocates, because I do think that, the problem is more than the individual. So we need to have other people be involved.
Absolutely. And you're president of the ACC, and I'm incoming president of the AHA. And I think that is in a sphere where things can be done, right? Because cardiovascular societies are major influencers, not only by just the guidelines the societies do, but the funds that societies can invest ultimately in making progress towards making progress along different lines. So, I think guidelines, being involved in guideline writing and infusing social determinants of health into the guidelines. We were able to do that for the primary prevention guideline in 2019, for example, the HCCHA guideline. And that goes right into the clinics for doctors to give them advice about how to, approach the care of their patients by infusing social determinants of health. I would also say, investment in research, as for American Heart Association, for example, there's like $100 million, invested in research around blood pressure control. There's $20 million invested on maternal health, another $20 million on other hypertension control. So there are things that, sort of assist, and the goal of those efforts is to, one, collect and utilize data in a uniform manner so that we can actually get to better solutions for disparities. The other goal is to, sort of work with persons in the workforce to develop novel solutions, to solving these problems. So those are systematic things that, as a professional society we can do, and certainly for ACC, there have been the workforce initiatives that you mentioned, Dipti, that have been going on for several years. And then, I think, again, at the federal and state levels, I think this whole concept of really getting a computer system, actually, the country doesn't have that, that actually harmonizes the collection of data by race, ethnicity, and socioeconomic status across the country in a manner that then allows, our states, individual states, to set targets. That's something that was recommended by the National Academy of Medicine in their report. The other part is giving grants and funding that not just only focus on, how do you solve a specific cardiovascular issue, but how do you tie in economics, to solving a cardiovascular issue. So there are a lot of different upstream things, I feel like that can be done. Lastly, I will say that, again, we keep going back to pathways and pipelines of trainees, but it's like absolutely crucial. We know that, although our medical school classes are 50% self-described women, for example, that, women don't get to the higher levels of medicine, C-suite, chairs, deans, etc. Similarly, for persons from underrepresented in medicine backgrounds, not even really entering the pipeline much, but not getting to senior levels. We have to be, as Ed was mentioning, very intentional about how we move people along the pathway, and pay attention to and work in our communities to improve early childhood education.
Right. I think you bring up a lot of really great points. Ed, what do you think are some of the institutional things? And maybe you can describe some things maybe that are even being done at Morehouse.
Well, I think, I hate to be so prescriptive, but I think it's important when you ask about what can a physician do daily to make a difference. But I think getting involved with a team, there are a lot of different opportunities for patients to afford their medication and to get help. But we have to, as a physician, get more involved in the team approach. We have to meet with social services. I'm in academia, and sometimes we delegate those things to the intern to kind of meet with social services and those type things. But you have to get involved. I mean, I've downloaded apps on my phone to give to different patients to help them pay for their medication. These are the type things that you can do as an individual to potentially make a difference. Um, it all evolves around economics. So if you have a patient that can't afford their medication and can't afford the procedure, guess what? They're going to come back to your institution a few months later. I mean, they're not going to go away. So having the administration understand these things and put in place different programs to help these patients navigate the system is critically important.
Yeah, and I think that talking about some of the solutions that involve government and all of that, I think it's important. I think the data collection is important.
Yes.
Right now, every patient that comes to the hospital for anything, emergency room, outpatient, whatever contact, there's an opportunity when they're registering those patients to collect some of the data for social determinants of health. That's not
Yeah.
being done.
Yeah. Yeah.
And go ahead, Michelle.
No, I was going to say it's not just only at our hospitals, it's also at larger state and federal levels as well. That the adequate data collection is just not there. And then understanding, who we're collecting data from and who we're not collecting data from is also important as, part of this process, and figuring out where disparities exist. Dr. Sonia Angel, in our Achieving Health Equity session at American Heart Association, mentioned that, understanding who's not in the data as well is important.
Yeah.
And she pointed out the fact that, sort of for incarcerated persons, they're not in the data. And they're, sort of part of where, how health disparities arise. I mean, I think the other thing we haven't talked about here from a solution perspective is having our institutions actually act as anchor institutions,
Yeah.
which means that the institutions must have a vested interest in their local environment,
Mhm.
in locally improving their neighborhoods,
Mhm.
locally employing people from their neighborhood, from their surrounding communities, being focused on the disparities in their communities,
Yeah. Mhm.
and providing volunteers from their systems, because we're all in oftentimes very large, powerful systems
Yeah.
that
Mhm.
have an opportunity to be able to work directly in the community to improve the lives of those persons in their communities who are oftentimes from diverse racial and ethnic backgrounds. I mean, and I also want to say, you know, we're talking a lot about African American and Black persons, but disparities exist, you know, around multiple other populations, including other racial and ethnic populations. The Asian Pacific Islander population is one that has a lot of disparities. Filipinos, Vietnamese populations, various races and ethnicities, Native Americans, rural populations, disabled persons. So I don't want us to leave this LGBTQ plus population. I don't want us to leave this discussion today without acknowledging that there are other populations besides Black and African Americans who have, you know, really terrible disparities. And oftentimes there's intersecting identities that that even, you know, sort of further uh, amplify the disparities and the syndemic type circumstance that Dr. Childs was mentioning, which is an epidemiologic term actually for for what's going on with COVID for minority communities, for example.
So let me ask you, so we've talked about some of the solutions potentially, but you know, health equity issues have been around for a long time. And granted, the pandemic just shone a light, but there have been a lot of people that have talked about solutions. And some of these solutions are not new. We've talked about. Why have they not worked? Or is it that we haven't, I mean, is it that we haven't had the national conversation? Or we haven't really put enough attention? What's the reason? I want to know why we haven't put some of these already in place.
No, I think they are working, and I think they may be working on a smaller level. Across the country, as far as the COVID-19 was concerned, the vaccination was a significant issue. And there was early evidence that the minority population was not taking the vaccination at the same rate as the majority population. But that was not true at a place here like Morehouse School of Medicine. And I think the reason why that was not true is because of all of the things that Dr. Albert mentioned earlier was working in the community, establishing a level of trust and understanding. So it was the reverse. We had a huge, tremendous number of minorities coming to Morehouse School of Medicine to receive their vaccination. And I think it is working on a small scale, but we need to amplify that scale throughout the country. And I think the work that we're doing, the discussion that we're having today, helps us to put a national light on some of these issues. So why can't we replicate that same process at Morehouse School of Medicine throughout the country to establish that level of trust and understanding where minorities, people in rural communities feel comfortable coming to an institution because of that level of understanding and trust?
Well, gosh, Ed, I couldn't have set you up better for one of my passion topics, which is that the way you scale health, I mean, how we're going to scale this is through innovation. So digital, you know, the digital transformation. I mean, we just had, you know, pandemic gave us a gift. And if that was the one gift they gave us was this whole idea that we can go digital, right? I mean, we did for a period of time. During the height of the pandemic, the data shows that about 90% of us were on telehealth. And granted, now in cardiology, that's gone down to about 30 to 40%, but it shows that we are capable of doing this. And the digital transformation may be a possible solution for this. So, you know, I'll open it up to either one that wants to comment about what do you think about that as a scale up. Now, I understand there's issues of, we need to be careful that we don't, we have to make sure those populations can use digital data, that they have the digital devices, so we don't create a digital divide, so to speak. But comment.
So I'm, you know, like yourself, I'm totally primed for this question because I moderated session on digital disparities at the last AHA scientific sessions. And, you know, the issues are multifold as it relates to Black and Brown populations. I mean, I think you were hinting to one, Dipti, where there is, you know, from an economic perspective, many people can't afford the broadband and the other things that are required to actually do the connectivity. There's also concerns about trust about how, sort of devices and information obtained by devices are going to be used. So it's still that trust issue, right? And, certainly I know for my patients, my African American patients, oftentimes will say, I don't want to do a video visit in general, but they'll do a video visit with me,
Yeah,
and,
yeah,
and
yeah.
so it gets to, in part, who is, sort of interfacing with them, who's delivering the message. But I think underscoring the digital divide is going to be access to computers, access to the finances necessary to actually, be able to utilize this stuff. A lot of people have their internet on a card, that runs out, after certain usage. And so I think that while it is something that increased connectivity during the pandemic for many, I don't know that it's sustainable without more connectivity between the federal government in terms of approaches and our tech industry in terms of approaches.
But am I being too simplistic by thinking, and I've spoken about this, saying that I believe that digital transformation may be a solution for for health equity?
I think that, I think you might be being too simplistic because, and the reason I'm going to say that, I'm going to give the example in current day with our vaccines, right? Our vaccine, for COVID, we know that, decreases hospitalizations, certainly almost 100% protects against, death, in if you're not, don't have certain other risk factors. Now, we know that it's important to do that, right? But if you parallel that to the digital um, uh, access, your comment that it will decrease disparities. You look at the two, and you look at the, sort of the trust issues and accessibility related to economics. You begin to see certain parallels where it's not as simplistic as that. It's actually even more fraught with stuff because you're collecting people's data oftentimes, and people don't know how that data is going to be used.
Ed, what do
But
you?
I do think it's an opportunity. So we talked about earlier how, health is more of an investment versus looking at it as a capital business model, in my opinion. But the innovation in IT is driving the economy. And everything is moving that direction. Currently, I think the statistics are kids the age of 17 to 20, 92% touch the internet 3 times per day.
Mhm.
So it's actually driving the economy. So we have to take advantage of that opportunity. We have to take advantage and get in line with what's driving the economy and provide the education and all of some of the things that we're talking about on this conversation to help um, spread education, to connect to the community, to inform the individuals. So I think IT is very important to hopefully get in line with understanding some of these things that are affecting healthcare disparities.
Well, there's obviously so much more I could talk to you both about, but I know that we have an audience and we have a lot of people wanting to ask questions. So maybe I can start off by asking Thad Waits to ask the first question or a comment or a question or observation, Thad. Thad's from
Hi,
Mississippi.
thank you, Dipti. Yes, I'm part of the state health board here in Mississippi also. And what I wanted to point out was in the earliest phases of the pandemic, the death rate from COVID was, as Michelle had said, was higher among the African Americans. In fact, it was 65% and 35%. As we got down toward the end of our second year, that exactly inverted. And the white population was 65%, and the African American was 35%. My observations on why that happened was, first of all, the health department had a fantastic PhD, Dr. Victor Sutton, who was directly, passionately in charge of getting out the message to the Black population. Then beyond that, we really got the ministers of the state involved, and the African American ministers were much more passionate than were any of the white ministers. And I think both of those things, as well as other things, were very instrumental in inverting that death rate curve. And just wanted to give that observation.
Thank you, Thad. Dr. Joe Marine from Johns Hopkins is our chair of Board of Governors, and he also has a question. So Joe?
I just wanted to thank you for your great comments and recounting that when I was a first-year medical student, one of the first lectures that I received was from the president of the Kaiser Family Foundation, and he gave a very convincing argument that education was a more powerful influence of health than anything that I would do in my career as a doctor. And so my question is, what can we do as health professionals to help improve our educational system, particularly the damage that's been done by the pandemic?
So this gets to a comment that Dipti and I were talking about before we came on. Thank you for that question, Dr. Marine. I was saying earlier that, when ever I'm asked about, what can an average American do with regards to health disparities, I say to them, look at your school in your neighborhood. And if that school is not diverse, then you need to ask why not, and follow that trail. And typically, and that gets to your point where about education. So certainly, if you're in a school system and you're a parent, and your school is either predominantly, one race ethnicity or predominantly another race ethnicity, you need to begin to ask, so where is everybody else? And why is everybody else in that other neighborhood versus this neighborhood? And then work with your local government and local school system to, on measures to improve that. And how might you improve that? Are there tutoring programs, at the local level that you can participate in that bring in, others and set up groups where people can meet each other? One of the things that I do in my research part of my life is we have something called diversity, DIVERSECITY, and it's a program where we bring together kids who are between the ages of 9 to 12 years old on the basis of socioeconomics. What that does is that it brings together kids from all different racial and ethnic backgrounds in a basketball camp. We folded it into a research study, and it improves trust across the races. It improves how kids see each other, and shapes potentially, what their vision is and what they want to see for the future. So I think there are lots of things you can do at the educational level. And it may involve sports, it may involve teaching, tutoring, etc. But I think, following the trail in your communities about, sort of what little things you can do.
I also wanted to comment about the work that's being done in Mississippi. I have had an opportunity to look at some of the work that's been done at the University of Mississippi through Dean Woodward, and some of the statewide network that she has established to collect the data and to address some of these issues. So I applaud all of the work in the state of Mississippi.
Ed, do you want to make a comment about the education? Because we chatted about that a little bit before we started this segment.
I think education is fundamental to this, understanding this pandemic and understanding the disparities that's associated with this pandemic. And not only educating about the disease process, but also educating about access to healthcare, some of the treatment and some of the options that's associated, and some of the things that we can do. And also connecting with the community and some of those centers that are making a difference is very, very important. So exposure, access, education are all very important in addressing these issues.
Great. We have another question from Brett Staggs. Brett, are you on? Can you ask your question?
Yes, hi. I just started at the beginning of November in mobile tools, and I was just struck by how much reach those apps have in all of the offices that they're used in. And I just started to think if there was a way that we could incorporate something on a new level into these mobile tools that could gain analytics or data on those health disparities as they're happening in quote unquote real time?
So lots of companies, principally places like Google, are on the trail to actually collect, and Apple as well, on the trail to collect our health information to help to answer work in clinical trials, but also really work to focus on health disparities. It is still challenging for them. You know, if you look at things like the Apple Watch study and so forth, still this issue of cost. So to get the app, you need to have, you know, a usually a phone or a watch or something like that, and then you usually have to pay for it. So the fundamental issues still exist related to, you know, the investment and economics around, you know, sort of how you put people on a level playing field. Apps and so forth tend to work for, you know, persons of higher socioeconomic status backgrounds, and occasionally for millennials who are diverse.
It's interesting. Cheryl Pegas was, she's chief medical officer at Walmart, and she had come to give a talk at a quality forum and mentioned that, you know, addressing some of these issues, especially about the digital divide, that they're going to be putting kiosks in the Walmarts so that people that don't have broadband can come in and utilize that for doing their telehealth visits and all of that. So I think people are thinking about really creative solutions. You know, I think, Michelle, you addressed the issue of what do institutions do? Well, we started at the American College of Cardiology launched a task force last year on health equity. You know, I was chair of that. And really, we've made tremendous progress in a little more than a year in terms of creating a strategic plan, making sure that that does become, as you said, part of the culture of the college. And hopefully when you're on the board, you can see that, and the question is how to go ahead and push that. So Rana Parekh, our Chief Diversity Officer, has a question with regards to that. Rana, do you want to ask your question?
Sure. Good morning, everyone. And let me just start off by saying how wonderful this has been. I thank you, thank all three of you for being strong advocates for health equity. My question is more around strategy and leadership. People have short-term memories, and I know with COVID, people are thinking about health disparities. But when we get to post-COVID, and how do we maintain the momentum, the energy, the resources around eradicating health disparities? And I'd like to ask each of you that.
Thanks, Rana. Hi, how are you? And thanks for that question. I actually think that maintenance of it is going to need to be on three levels. I think on the first level, and I think this is the base of the triangle, it goes back to actually workforce, right? If you have, you know, the workforce flooded with persons who this issue is near and dear to their heart, and then you actually put investment around, you know, their work, then you can, you know, sort of keep this, you know, sort of topic and the solutions related and hopeful solutions related to it propagating. Because, you know, I want you to, you know, Rana, I don't have to tell you that, you know, there have been people in this space for a long time, but what's happened in the last 2 years is that those people in the space are getting more recognition, not getting necessarily more funding, but, you know, certainly more recognition around what the work and the important work they've been doing. So if we can actually increase the numbers of folks who have the opportunity to do this sort of work through mentorship and sponsorship, and then continuing the financial support to get people to the leadership spots, from a strategic, you said strategic and leadership. I think we can keep this going, but you're absolutely right. The business of healthcare, business in general, you know, things have a, you know, 4 to 5 year span. We have short attention span, and people keep moving along. But I think it lies in workforce. And then I want to pivot, and then I'm going to stop to something that Dipti mentioned earlier, which was Dr. Cheryl Pegas. Dr. Pegas, as you know, used to be the chair of the board for the Association of Black Cardiologists. So she knows very well how disparities happen, and has been working in her sphere to really have influence on a more systematic level. Yeah.
Ed, do you want to make
Sure,
answer?
Dr. Parak, first of all, thank you for that question, and I applaud you for all of the work you've done for a lifetime, actually, in this area. But I think what's very important and critically important is to take advantage of this crisis. During a crisis, you can develop the infrastructure that you need to sustain these type of missions. So when we have the attention of the country and the world, to put in place some of the things to increase the pipeline, to review some of our programs, the funds to sustain some of these community programs that can reach the patients are very important. So I think taking advantage of this crisis to develop the infrastructure will be very important for us.
Yeah, and I think, Rana, you asked that all of us comment. I do think that for me, I think the discussions that we're having are very important. I have not seen this type of sort of national discourse, number one. Number two, I think to try to frame it in ways that people can relate to the issue, making them care about this. That's why I asked that question earlier, I think is very important. I do think that when the triple aim was launched in 2007, everybody embraced it. Institutions embraced it, but then they recognized they couldn't achieve it. So then it became the quadruple aim when they recognized that the missing piece was the clinician. And I think in 2021, my leadership page that just came out talks about the quintuple aim. And I think that it may sound like we're just coining a term, but I think things like that make organizations stop and pause and think. And I think the quintuple aim is the quadruple aim with the health equity as part of it. So now it's the quintuple aim. And I think to have that going into the C-suites and saying, no, you're not just achieving a triple aim or quadruple aim, but you really need to think about this will help. So I think more discussions like this, and you're right, the shelf lives can be, but I think the economic picture that's associated with health equity is so incredibly important. I mean, Michelle, you highlighted the fact that when you have health disparities, you're taking those people out of the workforce. And what does that do? And, it's interesting to me that we've always talked about economic growth as a way to cut healthcare costs. You're going to grow the economy if you cut the healthcare costs. Why? Because 16% of our GDP is on healthcare costs. But yet, at the same time, what if we reframe it? This is the perfect time to reframe that. And instead of saying we need to talk about cutting costs, let's make an investment. What's the investment on? Good health for everybody. Well, guess what? That's about health equity, the discussion that we're having. So anyway, that's my answer. Paul Douglas is on the line. Paul is now the chair of our Health Equity Task Force. Paul, do you want to come on and ask your question?
Good morning, everyone, and I've enjoyed this discussion. Thank you very much for providing this national discourse. One of the things that I wanted to ask each of you is the role of individual bias as it relates to health equity. What is it that we need to do on an individual level? One of the things that I think that that we have not talked about this morning, and one of the things that I think is fundamental to our discussion in achieving health equity is the role that institutional racism plays in the structural problems that exist in this country, not in just this country, but globally as well, where we see people who are undervalued, we see communities that are under-resourced, and that contribute significantly to the disparities that we've been talking about this morning. But we each have an individual responsibility, I think, in terms of understanding our own biases and helping us deal with these inequities that we see in all of our society. So I would just love to hear each of your comments in regards to that.
Dr. Douglas, first of all, I want to applaud you for all of the work you've done here in the community in Atlanta with Herman Taylor and Dr. Wanye and Dr. Eccles. And all of the work you've done for the ACC. It's been tremendous. You have been a champion in leading those efforts and in understanding some of the biases that's associated with our community, and also putting into effect some solutions. So thank you for all of your work. I think you're exactly right. You're 100% correct. Some of the work that Dr. Pyrank has done with the college, and some of the work she's done throughout her career, is to educate on bias, unconscious bias, conscious bias, microaggression, all of the things that affect the system that may lead to health care disparities. So education is key. Keeping it at the forefront of the conversation and being able to acknowledge some of these differences.
Michelle, you're unmuted. Can you speak now?
Yeah, I can speak now. So hi, Dr. Douglas. Thank you for your question, and it's great to see you here. So I think, in answering your question, it's important to also acknowledge that in addition to bias for patients and their families, that also healthcare providers who are of different racial and ethnic backgrounds, particularly Black and Brown, also experience bias, both from their administrators and colleagues, as well as patients and families, and so it's a whole problem. In terms of, I feel like at the individual level, as Dr. Childs mentioned, really increasing awareness of the inequities, and we've certainly gone through a national conversation around that. I think 2.0 version of increasing awareness is going to be understanding how the awareness increasing has impacted outcomes, if at all, right? Because then one needs to reshape the conversation. Also, increasing personal bias awareness is going to be important. Having a motivation to control prejudice is key, because everyone is biased. Enhancing empathy is another part of it, as it relates to some of the interpersonal bias, and also addressing, I would say, interracial anxiety that is a big deal, right? Because it results in avoidance and results in less therapeutic relationships between patients and physicians, and then that ultimately can accelerate healthcare disparities. I would say that at the institutional level, one of the major things is going to be what we've already been talking about, which is diversifying the leadership of institutions, who can then help to address disparities. I think also decreasing physician cognitive load, because when you're cognitively loaded, the push towards having really quick answers, short solutions becomes more evident, and also having our institutions be accountable. And what that means, again, is really improving the diversity in the C-suites and in the upper leadership, but also, having people be judged and measured, their success judged and measured on improvement in equity statistics in their institution, and the therapeutic relationships. So those are some of the things. I know I was a little bit long-winded, but I think that they're specific things.
When we launched the Health Equity Task Force, the discussion of racism came in, and I can tell you that it was a difficult discussion, because I think because it evokes a lot of emotions, right? Because we think, oh, I'm not racist, but of course we all have biases. I think that given the fact that we're having that discussion, the question is how to make that discussion less emotional in some ways, because it is an emotional discussion. But I think we're having those discussions now, so that's a good thing. And I agree with a lot of the things that both of you said in terms of some of the solutions for all of that. But Michelle, your point about being a little less stressed. So my last coffee was with Vincent Covello and Randall Heyer, and it was about stress communication. And I do think that have a meaningful conversation about racism and bias, all of that requires that communication piece. But, you know, as Ms. Covello said on our last coffee, he said, when people are stressed, they stop listening. It's difficult to have communication. So I think that being a little less loaded with things allows you to process all of that. And I also think it goes back to how do you process it, you know, and what are things that you can do. So I think we need to talk about it openly. We need to have tools to be able to manage the emotions while we're talking about it, and then potential solutions that we can feel like there's an avenue. It's hard to talk about things when there's no answer, so to speak.
Right. Right.
So I think
And we have to reach across the aisle. You know, what we don't want in these conversations is that we don't want, you know, and we're seeing this increasingly in the healthcare academic institution workspaces where, you know, the groups that have been, you know, traditionally dominant are becoming more silent because of fear of saying the wrong thing, retaliation, etc. And, you know, I think the thing is that these conversations are never going to be comfortable, right? And so let's, you know, acknowledge that. But we have to have, you know, empathy for each other, and realize that fundamentally we're human beings to start with. And, you know, it sounds cliche, but we're more alike than we're different, right? And starting from that perspective, we need to start with basic respect for each other and recognize that, you know, we bring certain things to the table based on the tapestry of our experiences that are valuable, regardless of if you're white, blue, green, red, yellow. You bring something to the table.
And understanding, I think, those stressors and making sure we frame the conversation as a win-win for the entire population. So I think diversity is a win-win for everyone.
Right.
right. All right, well, we only have a few more minutes left, so I want to give both of you sort of a closing remark. So Michelle and then Ed, or actually start with Ed first, and then we'll give Michelle the last word before I close up. So Ed, tell me your thoughts. What is the one thing you would like for our listener to take away?
So thank you so much for having me this morning. It's been a pleasure to be with you, Dr. Itchhaporia, and also Dr. Albert. So thank you so much. I think one of the things that I would like to have the audience take away from this conversation is that the importance of diversity and the importance of being involved and getting involved. And I think on a small scale, each one of us can do something to make a difference in the overall structure of what we see in healthcare disparities, from caring to calling to getting involved with patient issues. All helps in solving this problem. Getting involved with local organizations, getting involved with national organizations like the ACC and American Heart Association, and all of the great work that everyone is doing. Also, leaning on those people that may have figured it out on a community level, I think is also very, very important. Lean on those institutions like Morehouse School of Medicine, all of the work from Dr. Pyrock and Dr. Douglas. Lean on those individuals to help create solutions.
Michelle?
Yeah. So my closing comments are simple. I think that whenever you approach any situation, you have to start with some guiding principles, and utilize those guiding principles to then develop strategy for tactical strategy for what you're going to do. So I think the guiding principles that I am thinking about around this would include one, that it is important to be present. It is important in your presence to listen and to learn, and then follow the trail of listening and learning to action. I think the next guiding principle for me around this would be the fact that what we're mentioning here today is that we have a shared economic and health fate. And you know, certainly for climate change and all of the other things we see, health disparities, the same thing. We have a shared faith. So we need to have solutions around health equity that build in the fact that we have the shared faith. I would say partnerships is an important guiding principle that we need to follow. And you heard Ed Child say, partnerships at the community level, but also we need partnerships at the state and federal level as well. And then finally, the other guiding principle is that we talk about health, but I actually put wellness, in a bigger sphere than I actually put health, right? Because health, moves into wellness. And if we think about wellness, then wellness deals with stress, it deals with economics, it deals with all the things that, are the core of health inequities. So I would tie it up to say those are the guiding principles, and then move from there to try to address health inequity and disparities. And I want to say thank you so much, Dr. Itchhaporia, for having me on this program. I found this discussion to be really exciting, and and congratulations on your presidency, and you're doing a really fantastic job.
Well, thank you so much. I really want to thank both of you. So thank Dr. Michelle Albert and Dr. Ed Childs for joining us today at the virtual ACC coffee table. These recordings for these sessions are on the ACC YouTube page, typically a few days after the event. And then look for our next coffee, which will be in early January. For those of you that have joined me before, you know that I always like to end with a toast. So here we go. This time I don't have my actual coffee mug, but here we go. May your coffee be strong and your day be full. May we help, may we heal, and may we advance heart care worldwide together. Thank you all for stopping by. It was a pleasure. Have a good day.